I spent recently, last several years, trying to think a little bit about evidence-based medicine. What does that mean? Kind of initially made me cringe. And it seems bigger than that. Am I on? I think I am, aren't I? Am I on? But at any rate, as you ponder some of these things, it's hard to get, at least for my head, to get around what we mean by evidence-based decision-making. And as a kid, I read a lot of Sherlock Holmes. Having 5 kids, I had the opportunity to buy it again, so I could read it again. Kids didn't. But at any rate, this exchange, as I was reading one night, really struck me. And that was Dr. Watson, who is the creative, passionate, sensitive guy. He would be the same as Dr. McCoy if you watch Star Trek, right? So Dr. Watson McCoy, this is indeed a mystery. What do you imagine that it means? And he's conjuring up all these what-ifs. And Sherlock Holmes would be more like Spock, right? Totally rational. And Sherlock says, I have no data yet. It is a capital mistake to theorize before one has data. And what really got to me is I'm interested in how people think. And so insensibly, without knowing it, one begins to twist facts to suit theories instead of theories to suit facts. So this was written in 1887, and Spock and McCoy did it again, and I think we just do it every day. I think it's part of our human nature. So that's why that first slide is on there. But then, being a simple guy with a few brain cells left in Walcott, I got to thinking, diagnosing disease, that's my topic. Well, what the heck's a disease? Dr. Walters and I have argued about this. Disease to me simply is altered structure or function. We do pathology, we do tests. It's measurable, and for our purposes here, I think it has to have some clinical significance. What is diagnosis? Diagnose the outcome of investigation, putting a name on whatever this disease would be. And we use evidence, diagnostic lab data, a whole raft of evidence to determine or try to get closer to the accuracy of a diagnosis. And what that implies to me is there's an element of confidence and uncertainty. When somebody renders a diagnosis, when I tell Dr. Williams that his pigs have strep suis, there's a certain amount of confidence around that. And there's also a certain amount of uncertainty, as he well knows. So that's why we can diagnose things at a variety of levels. Clinical diagnosis, yeah, they're lame. And on down the line here, maybe they got arthritis. Yeah, the PCR is positive. That's also a diagnosis. So you get this different levels of diagnostic accuracy, if you will. And most of what I spend my time doing is asking the question, does it make sense? Do we have diagnostic alignment? So that's not very profound. But none of this is actually, But I think about, well, and it's because of where I sit in diagnostic lab, Your diagnosis is this, so therefore it's cause. What is causation? Cause is something that comes before something that happens. It's a reason for why something would happen. And causation is a whole philosophical argument, but from where I sit, a diagnosis doesn't have to have anything to do with cause. It may, but it surely doesn't have to. And thanks to Jared Diamond and the book Collapse, I think about, the obvious cause, and then I think about the things that are risk factors that go into that, what he calls proximate cause. And I think I can illustrate that just a little bit with this busy slide here, where we have basically suckling pig diarrhea. And all of you know all the things that go into that, the environment, the dam, the colostrum, the infectious agents, management, nutrition, whatever. But from where I sit, most of the time it seems as though we have a concern that's identified. Pre-weaning mortality, weaning weights are down, or somebody calls it diarrhea. Go to the farm, sure enough you can find diarrhea. So the next step then is to send something to the lab, find an infectious agent, right? We look for what we know, we don't look for what we don't know. And then we call it something. We diagnose an endemic agent. We call it a disease. I don't know if we truly established causation here or not, but from where I sit, it looks like sometimes we think we have. And so, astute practitioners try to solve the problem with a nostrum, and if it works, great. I think they probably did find the cause. But many times you have to go back and look at the entire system when you're dealing with the ultimate causes that contribute to diarrhea, right? And if you've been watching the economy over the last several years, there's this guy by the name of Nassim Taleb that wrote a book called Black Swan. And, he really focuses on what we don't know. That's what really hurts us. And there's a whole lot of unknowns in every barn out there. We assume we know what's going on, but I'm not sure we always do. So the real take-home message I guess I'm getting to is the need for thorough assessment of all the risk factors that are there. So I'm going to start with the assumption that circovirus and mycoplasma are endemic disease. I'm not going to talk about monitoring for something because we don't think it's there. We're basically focused on diagnosing something that is there, right? And the question is it there today? You just do a test, a very sensitive test, and yeah, you can find it. You expect to find it. Has it been there? Well, that's an antibody test. That's not too tough either. Is it significant to this pig? And then sitting in a diagnostic lab, we get this little box of tissues. And, you do these tests and you look for lesions. Microscope slide is about the size of your thumbnail, 3 microns thick, right? And I get this call after you report the results. Well, what does it mean? And I'm going, just what it says. Tests are positive, tests are negative, you had a lesion. Yeah, but what's it mean, right? Is it significant to this pig? Well, that's one question that comes to mind, and I think we can kind of answer that if we're fairly careful in our necropsy. The extent of the gross lesions is a big deal. The histo basically is a QA/QC to make sure that what we're finding is compatible with what you saw grossly, that what you saw grossly was real, right? And then it also helps point different directions for etiology. So in case we're on the wrong track, we can redirect our diagnostic investigation. So, but it's your gross assessment, being on the farm, that I think that really helps us establish whether a disease is affecting this pig. Well, that's not really all that important either. If you got 1,000 pigs and you got endemic infections and you expect some to be there, finding them is no big deal. Finding a lesion is no big deal. So the real question becomes, what's the impact on the herd? And part of what I'm here for, I think, is how do you trust your diagnostic information, that it represents what was happening in the herd. And the big thing there is representative samples. Your diagnostic question, the representative samples. And are we looking at this in the context of time? Because 1,000 pigs are not peas in a pod, they're all different. And so they're changing dynamically over time. You have this distribution that's changing over time. And I was really, really struck with Tyler's talk, looking at data. Because I think if you're doing herd impact, I'm not sure how I can help you. I can kind of do, is it there or not? Is it causing a lesion or not? Help you verify that. But the stuff that goes on with BI and the field trials and the field design, trial design, I think is about the only way I know, really, to do a herd impact, right? I don't think you can do it from a laboratory. How about in a vaccinated herd? I guess my take home is it doesn't matter to me. I just don't use antibody anymore. Concepts are the same. They've been vaccinated. Do I care? No. For 30 years I've been diagnosing disease in animals that are dying of what they've been vaccinated for. So, okay, anyway. Endemic infections. This is just kind of a recent data that looks at, this one at the top in 2003. This is the frequency of diagnosis of disease agents. The one at the top in 2003, January 1, is PRRS. It's also the one at the top, January 1 of this year. So PRRS, I'm not sure we're making any progress there in terms of, this isn't good data, it's just what we see. But frequency of diagnosis, it's still there. This one down here that bounces around and pops up, goes back down. Thank you very much, Circoflex and circovirus vaccine. It seems to be working. Mycoplasma is kind of the topic today. What's it been doing? It's bouncing around. as is flu, you know. And of course, the cynical me goes, what kind of impact are we really having? I'm not sure, but circovirus obviously one, but after that, not sure. Okay. Problems in diagnosis of circovirus in individual pigs, and this is a question that comes up a lot. You know, you go pick out a pig that's waste and has clinical signs of circovirus, whether it's 1%, 0.5%, or 30%. You pick out the pig, send it in. We're going to look for lesions, and we're going to look for IHC stainings, is how we do it, right? And of course, the classic lesion, you got to have the three things, you know, lymphoid depletion and wasting of the pig, lymphoid depletion, and then IHC positive. And I've always been kind of troubled by, well, what if it isn't really lymphoid depletion, but you have some staining somewhere? IHC isn't really all that sensitive of a test, and I look at some of these. This is a picture of a gut. Pyrus patches are really loaded with virus. Here's a picture of a young pig. This one's still only 6 weeks old, and we got macrophages are laden with circovirus already, but the morphology hasn't changed much yet, right? Is that virus important or not? I'd probably answer that kind of like I do with PRRS. Is this PRRS important? I would say no pig is better off being infected with PRRS. So, you know, when you can find a virus like that with a not very sensitive test, I got to believe it's a problem. The good news is we don't find it as near as much as we used to. And then we have this whole issue of, you know, if PRRS goes where inflammation is and you find some macrophages in a liver here, are they important? I'm not sure. But if it ends up looking like a liver like this, then you go, well, I wonder if that's compromising performance, nutrients, metabolism, whatever. Likewise, kidney, the non-suppurative foci that we see in kidney now. Is that a sequel to circovirus? I really don't know. My expectations for the circovirus vaccine is it's going to eliminate clinical effect if it's efficacious. It's going to probably eliminate lesions. This one, yeah. Mitigate is what it's supposed to be. Mitigate lesions, and then probably eliminate IHC positives. And this is the success story part in my mind, and you guys are all aware of this. IHC positive and negative for circovirus. As you can see, we're doing testing. We're finding about half positive, half negative. During the epidemic, it goes on up, tons of positives while negatives are going down. Negatives have gone down, positives gone down. So, backwards. Negatives have gone down, and positives are really down here at the bottom. So, you know, I think I've seen I think all of us would probably agree the only mandatory vaccine out there right now is circovirus vaccine, right? You can't get by without it. So diagnosis of circovirus in a non-vaccinated pig. Is it significant to this pig? Send it in. We'll do the IHC, find some virus, and go yeah or no. Is it significant to the herd? Back to the assessments that Tyler was talking about and your BI folks are talking about. Really leaders in designing good field trials. You know, did the pigs submitted to the lab represent the problem you're seeing? Did we look for stuff other than circovirus, other than what we're looking for, right? Do we use some histopath? Do we collect good samples? And then it kind of comes down to field trials and designing ways to assess interventions, I think, and clinical response. I mean, the data that anybody would show up here on a farm or a trial is just something to think from. I think to know how to implement it on your own farms, you're going to have the ability to put these trials into use to see if it's really working or not. Mycoplasma, switching gears just a little bit. This is the trend over the last, 7, 8 years of mycoplasma, frequency of diagnosis of mycoplasma in the diagnostic lab. And it's, you know, I don't know if it really went down here or not, or whether we were just busy looking for circovirus. But at any rate, you know, it's still out there. We still find it, and we still find lesions associated with it. Hence, we would call it a diagnosis of mycoplasma associated with pneumonia. Not necessarily acting alone. You can have more than one diagnosis, right? Right? Okay. More than one diagnosis. Pretty good seasonal effect with mycoplasma, as there is with flu, and there is with PRRS as well. Circovirus doesn't seem to show that. So this is just all the aggregate of the last 7 years with months along the bottom, right? And so, yeah, we sure do have more respiratory disease and mycoplasma in the fall and winter, fall and early winter. Diagnosing mycoplasma-associated pneumonia. I honestly cannot look at lungs and say much more than there's a bronchogenic pneumonia here or here. Cranioventral consolidation can be red, can be edematous, can be gray, kind of depends what bugs are in there, but it certainly has nothing to do with, it's not pathognomonic for mycoplasma. To me, it's a bacterial pneumonia, bronchogenic pneumonia, and probably I would be left with that until you actually do diagnostics. Diagnosis by microscopy. We look at great staining here in the airway epithelium, as well as over here. Peribronchiolar cuffing here, peribronchiolar cuffing here. So you go, well, that's flu, that's mycoplasma. If you didn't have the IHC there to differentiate, I'm not sure you'd be able to say that with certainty. Right? So microscopic lesions aren't pathognomonic either. Students probably get frustrated with me when I'm working with them because you ask them a question and they're really, really thinking, and then I go, the way to get an A in here is to answer, it depends. Right? It depends. There's no one right answer. So, diagnosis of mycoplasma-associated AD. Again, you don't need really super sensitive PCRs probably. You just probably need to get a little bronchoalveolar fluid and make sure it's there. Assess it grossly. Have some clinical science to go with it. Actually do some data capture would really be good. And look for other stuff. What else is contributing to it? That's how you'd estimate impact in a herd, in a individual. Impact in a herd. It's pretty much like circovirus, I think. Again, if you're looking for a recipe, an SOP, take this home and use it every farm, you ain't gonna. That's not going to happen. That's the whole basis of this talk is how. I think use those skills, right? What's right for this herd in terms of assessment. Okay. Same way in a vaccinated herd. I just don't differentiate. Disease and diagnosis. Several years ago, Edgar and others, initiated this MAGIC protocol. It was a heck of 1,100 cases, multiple, looking at all those slides and doing all that. But it was pretty cool, and I think really learned quite a bit, at least about sampling. Maybe we didn't learn anything about diagnosis, but about sampling. And so the MAGIC protocol, I think, is not a bad way to assess a herd to get a diagnostic picture, a picture of the diagnoses of the agents that are present in a herd, not only the endemic, but maybe something you don't expect. Using, acutely affected animals, chronically affected animals, let's try to get that temporal relationship. I think the serology, detection of agents, using oral fluids, probably has a lot of merit going forward. I think we're going to see a lot of that used for monitoring. And getting a picture, because I think the real key is trying to think of variation of distribution or populations today and how those change over time. And I know many of you are better at visualizing what that's like. But it just means that there's no single take-home message. There's no single one thing you can hang your hat on. You've got to be thinking and observing all the time. To summarize, not worried whether agents are present in the population. For this talk, I'm assuming they are. Are these agents affecting individual pigs? In this case, I'm assuming they are. Neither one of those vaccines, no vaccine's 100% effective. I certainly, have sat in boardrooms where you come up with strategy on January 1 of 2003, and we're going to address these two diseases, and you come back January 1st of 2004, and you send in some pigs, and you go, they're still there. Of course. So the question becomes, what's their impact and how do you measure that? And response to interventions and what is it we're actually measuring, something that really matters would really be good, I think. Again, I think I have to applaud BI, Dale Polson, for this type of thinking of statistical process controlled tools, of using data and visualizing data and being able to watch it, influence it, change it over time. I think that's a huge, huge thing. So, I guess it was mentioned earlier about Keith, setting up trials, avoiding bias, right? We can't avoid some bias, but we've got to be aware of it, We see disease with bias. We diagnose disease with bias. We diagnose what we look for. And then we assign cause with bias. And sometimes we got to think maybe there's more than one cause. So my little note to self every morning is kind of like, be aware of what I don't know or didn't look for. Because there's a lot of that happens in my world. So that iceberg does have a lot of unknowns, a lot of hiddens. So.